Good afternoon, friends, and welcome to this first session of webinars, which is a launching program today on management of children with COVID infection. This series of webinar will be webcast in 4 sessions every Thursday now onwards from between 12:30 to 2 p.m. And today, in this inaugural ceremony, first of all, I request Dr. Neena Rena, who is a senior advisor to WHO SEARO office, to give opening remarks. Madam Dr. Neena Rena, please. Madam, unmute करिए.
Good afternoon, namaste everyone, and Professor Guletia, Professor Loda, Professor Kabra. First of all, my compliments and my congratulations to all of you for organizing this very, very important webinar on management of COVID infection in children. As we all know, we are in the 10th month of the pandemic of this novel coronavirus that has presented us huge challenges to the humanity and this planet. The direct and indirect impact of COVID-19 on health and survival and economies as well is well known to all of us. There's a great leadership provided by Professor Guletia, on really providing guidance and collaborating with the Ministry of Health in India to really support management of this pandemic. There are more than 36 million new cases which have been reported, out of which more than 7.5 million from SEARO, from Southeast Asia region. India particularly has been facing a big burden of the outbreak that has now started showing some decline. There have been strategies which have been put up in place by the Ministries of Health to mitigate the direct and indirect impact of COVID in member countries. Efforts have been mounted to develop vaccine. Globally, it has been observed that children are much less commonly infected and have a milder disease compared to adults. It's usually the children and adolescents are ranging between 1 to 5%. The reasons for less severe illness in children is unclear and is a matter of further research. If the proportion of infected children is less, the number of infected children in populated countries in our region, Bangladesh, India, Indonesia, in quantitative terms could be large. However, a serious form of multi-system inflammatory syndrome temporarily related to COVID has been identified and progressively getting well defined. There are a lot of research publications related to this from many countries. And there's a guidance which has come from WHO as well. This could be associated with high mortality and chronic morbidity amongst children who get affected. We recognize, the WHO has produced global guidelines on case management and infection control that are being constantly updated based on new knowledge that is emerging since the onset of pandemic with this previously unknown virus. We recognize the need for providing standard treatment approaches that could be used effectively in resource-constrained settings like countries of operation where health system has come under great stress, including the hospitals where these children are referred to. We requested the experts at AIIMS, New Delhi, that is also hosting 4 WHO collaborating centers to prepare a series of webinars on managing children infected with COVID-19. And I'm very glad that in collaboration with WHO, SEARO, and AIIMS, there are 4 webinars which have been organized on this particular topic. And there are experts who are going to be talking and sharing experiences with the rest of the people. And we have widely shared it. A lot of people from other member states are also connected today on this webinar. The series cover a range of topics to support comprehensive management of pediatric cases And the main areas covered in the series are epidemiology, specific supportive treatment for mild, moderate, serious cases, infection prevention, protection of healthcare workers, and case reporting, etc. We are also supporting prospective study of pediatric cases in countries of the region to understand the clinical profile and disease outcomes. We sincerely hope that the healthcare teams in the countries of our region and beyond will benefit from these series of webinars and ensure desirable outcomes in the pediatric COVID cases. I would like to again thank Professor Galeria for providing leadership in this whole process and also creating a very congenial environment for different departments to really take the lead in setting the evidence and sharing and disseminating the information. My special thanks to Professor Cobra and put in this work and to our request so that other countries also benefit from this whole process. Thank you very much. Over to you, Professor Cobra.
Thank you very much, madam. Now I request Professor Ashok Kumar Devrari, who is Professor and Head of Department of Pediatrics. Under his leadership, we are working for these webinars. I request him to tell us about how to use digital program in improving our knowledge. And because it will be a new norm, Dr. Devrari.
Thank you, Sushil. First of all, let me congratulate Sushil Kabra and his team, who are ably supported by World Health Organization SEARO office for creating a series of webinars on COVID in children. I think this pandemic of COVID has given us an opportunity of harnessing digital tools to reach not only healthcare professionals, but the community at large. And we have been seeing in the last 8-9 months a series of ways by which we are reaching healthcare professionals and the community for making sure everyone is protected from COVID, and we report to hospital if we have early symptoms so that we can save lives. There are two different ways in which we can reach more and more people. One is typical webinar, as is happening today. It is a low-cost way of reaching more individuals at a short time with low cost. And then we need to innovate how we can make our webinars interesting or interactive. And I am inspired by my director who has taken a lead with EPIO in creating a series of webinars for COVID in adults, which it is having, in addition to webinars and case discussion, interactive sessions in which questions are even asked to the panelists, which clarifies the doubt of individuals. But this is one of the ways, which is a synchronous way, which is cheaper, by which we can reach large number of individuals. The second way, which we have to think for long term, is how can we create an e-learning package for healthcare professionals for prevention of COVID infections and even for management of COVID in children. And this e-learning package, if we want to create, what it will be, it will require more work. It will require more money because you have to create content. And then it can be put on a learning management system in which it is a asynchronous way by which healthcare professionals can learn about COVID management. The big part which is missing in webinar is you can inbuilt assessment also while you try to create e-learning content on an e-learning platform. So e-learning platform can be also used in a blended manner, as we have done at AIIMS New Delhi using a digital platform, which is a SEARO platform, in which we provided all the digital content for healthcare professionals who are doctors, nurses, who are working in COVID hospital. They were given assessment in the form of MCQs. They also connected virtually with the team of leaders who created that content so that frequently asked questions were replied on the virtual platform. So it was a blended type. And once that training is taken by the healthcare professionals, they were able to generate a certificate. Then they were done a demonstration of personal protection, which they have to do, like donning and doffing at the COVID hospital, and immediate feedback was given. So it was like a blended type of learning, which was using the e-learning platform for training of healthcare professionals. So I think these two examples which I have quoted, one is of national webinar with Niti Aayog, with our director has led, with interactive session, face-based type, and answering the questions for management of patient is one way. The second way is creating something on a e-learning platform, which is going to be a little bit costly, and it can be asynchronous. At leisure, the students can log in, go through the material, you can inbuild assessment, and then do a blended form in which the demonstration is done for donning, doffing, or the skills which the healthcare professionals have to follow in COVID hospital. So I'm so happy that we are using now digital technology for reaching more and more healthcare professionals, not only in India, but in the SEARO region and globally worldwide. And thank you, Sushil and his team, for taking this initiative on behalf of WHO CC at AIIMS. Thank you. Thank you.
Thank you, sir, for encouraging words. Now I request Dr. Rajesh Mehta, who is a regional advisor, WHO, in SEARO office, to speak on purpose and scope of these webinars. Dr. Rajesh Mehta.
Thank you, Professor Sushil Kabra. Professor Dr. Randeep Guleria, the Director of the All India Institute of Medical Sciences. Dr. Neena Raina, Senior Advisor from WHO Southeast Asia Regional Office. Professor Deorari, the Head of the Department. And my friends Sushil and Rakesh, the professors from the Department of Pediatrics at AIIMS. And I see 200 people connected with us today, not only from India, but from our regional countries. I see some names from Bangladesh, Nepal, Indonesia, and also from our European region. There are a few names from there. I can recognize some of them. So it's a good beginning to an important subject. As we understood from Dr. Raina as well, that this pandemic has put the health system into a serious overstretching and challenge. There has been disruption of services. Some hospital beds were diverted. There are shortages of beds in many cities. And there is both disruption in quantity as well as quality of services because of the challenge on health workforce and the supplies and all the logistics of delivering services. So there is a real, one has to acknowledge the impact of pandemic on the of our people and their health care. On top of that, the hospitals have to now undertake newer functions more emphatically, with more time for each child who comes with a suspected infection, to screen them, to triage them, which happens normally as well, but now this time it has to be increased, and then prepare for isolation if they are suspected or found to be positive with the COVID infection. So therefore, what we understand is that this moment when health system is a little bit overstretched, the quality and safety are paramount. So it is important that we ensure that no harm happens to the patients and their attendants and our own health workers. So that is an additional emphasis to be placed on our work in these days. So under these situations, we requested our experts in All India Institute of Medical Sciences to prepare evidence-based yet simple protocols that could be applied in hospitals of our low and middle income countries in the region and beyond, as standards of care for pediatric cases from birth to 18 years. So there has been a felt need and a demand from countries to get some standard protocols to treat children. So therefore, it is so nice that All India Institute of Medical Sciences in New Delhi has responded to our request. So the treatment guidelines and protocols are constantly evolving, as Dr. Raina mentioned. So therefore, we are prepared to actually update and upgrade our contents of these forward. So I must thank Dr. Sushil Kabra and Dr. Rakesh Loda for having led this work, bringing together a large number of domain experts and carefully preparing the contents of these webinars, which are largely based on WHO guidelines. And where WHO guidelines are not available, they have used the best evidence, published evidence available in global literature, and used the best clinical practice to provide us some standards of for pediatric COVID cases. Therefore, I am very sure and confident that series will meet, this webinar series will meet felt need of the people, the pediatrician community and physicians and nurses, so that they are able to treat the pediatric COVID infection in a very standard manner, in a cost-efficient manner, without wasting resources of unrequired treatment, because these webinars will give them a very standardized approach. And in addition to a continued medical education kind of approach, I am sure these webinars can also be effectively used for training of resident doctors in hospitals and training of nurses who are involved in pediatric care in these hospitals. So we are making sure that the recordings of these webinars, the voiceover recording of experts on various elements of pediatric care is being made available subsequent to webinars also. So all people can use these YouTube series to train their own residents in the hospitals and nurses in the hospitals. And going by my friend Professor Ashok Derari's observations, I think there is a scope to convert these webinars. These webinars is just one learning resource. To take them into a multimodal learning package as we move forward. It was urgent to provide the knowledge at this stage. Therefore, we thought, let's go ahead with webinars first and then look at some interactive virtual methodology to build a learning package around this set of knowledge. So I'm sure moving forward, we'll be able to deliver on that as well. So I think we must use technology for building back better. And All India Institute of Medical Sciences has contributed to our work in this area quite a lot. So therefore, it is my duty to thank them for this meaningful contribution to improve the health of children in the region and beyond. So I hope who are linked with us will enjoy this series and give us some feedback to improve further. Thank you, and over to you, Professor Kabra.
Thank you, Dr. Mehta. Now, I request our director, Professor Randeep Guleria, who is encouraging all of us to take a lead in not only managing children in our hospital, but to guide all the pediatricians all over. So now I request him to speak about overview of pandemic and provision of appropriate care. Dr. Guleria.
Thank you, Dr. Kabra. First of all, let me welcome all the experts, Dr. Rajesh Mehta, Regional Advisor, WHO SEARO, Dr. Ashok Derari, the Head of Pediatrics at the All India Institute of Medical Sciences, Dr. Neena Raina, Senior Advisor, WHO SEARO, and Dr. Kabra and Dr. Loda and the entire team. I'd like to congratulate both the Department of Pediatrics, the All India Institute of Medical Sciences, and the Southeast Asia Regional Office of the WHO, really holding these series of webinars on the management of children with COVID-19 infection. I think this is something which is really needed, and it is an evolving task. When we started with the pandemic, we knew very little about COVID-19. As a matter of fact, at that point in time, there were concerns whether children were at high risk, because we knew that at that point in time, when we looked at the previous H1N1 pandemic, pregnant women and the newborn were considered to be high risk, and there was a whole issue of trying to provide them with extra care as far as COVID-19 was, as far as H1N1 was concerned. But gradually we learned that children are protected to some extent. And initial data which came out from China suggested that it involved less than 5% of children were actually having infection with COVID-19, and it was usually a milder disease. More recent data suggests that a large number of children may be asymptomatic and have mild symptoms, and it may be much more than what we had initially thought. But very few of them have severe illness, but many may have atypical manifestation. Why this happens as far as children is concerned is something which will be interesting in terms of the immune system and other factors. I also think we need to really look at various challenges that managing children has thrown to us, and I'm sure that this will be covered in the webinar. One, of course, is the subsequent long-term manifestation that can happen in this after they're recovered, the multi-system inflammatory syndrome, which we are recognizing more and more now, and even reporting from our country as far as COVID-19 and children are concerned. But there are other challenges which we need to really address, and I'm sure this will be addressed because, as was mentioned, we have audiences not only from India but from the entire Southeast Asia region. And that is, how do we appropriate hospital care? Children are a unique group of patients because of the fact that they will have an attendant, the parents will be with them. And how do we really provide care for the child and the caregiver in terms of the parent? We've had this problem in our hospital that the child was positive, but both the parents were negative. How do we manage these patients in our COVID care center when the parents are negative? And you cannot have a child who has pneumonia and is in the ward without the parent, or one of the parents being there to provide care. So these are unique issues that we have had, and they need to be addressed also. Children also need special care because very often COVID-appropriate behavior, as we talk about it, cannot be sort of followed as far as children are concerned. There are also other concerns which have come up, and those are issues that we also need to really look about. These are areas which can also be sort of researched, and that is that we know that COVID-19 can also have eco-oral transmission, but that is rare or uncommon. But what about infants and children who are not toilet trained? Can there be some chance of that there may be a higher chance of eco-oral transmission in these children or infants who are not toilet trained, and therefore can that be a cause of concern? This, I think, is something that we need to look at, and I'm sure that this could be an area of research. There is also a lot of issues as far as prevention of infection in healthcare setting is concerned. We've had outbreaks in our hospital in the ward, and that is why I am very happy that you have a session on this, because there is a need for all healthcare workers to be properly trained as far as infection control practices are concerned. And it is different in adults and in the pediatric age group because there the close contact is much more. One other area which I think we need to really look at is the psychological aspects that COVID-19 is causing in children. Children are homebound. They are lacking the personal contact with friends, with classmates, with teachers. And this is really having other stress as far as COVID-19 is concerned, which is something which we have not discussed, but I think it is something that we need to look at it if we want to have a holistic management as far as children are concerned. So what I would like to really conclude by saying is that children need special care, and therefore these webinar series on the management of children with COVID-19 become more and more important, because this is something different from what is provided as far as adults are concerned. And I'm very happy to note that this webinar has been well by experts across multiple institutions, and therefore will be very useful in guiding pediatricians, physicians working not only in India, but in the entire Southeast Asia region. And I'd like to congratulate the Department of Pediatrics, Dr. Kubra, Dr. Lodha, for this excellent effort. And I'm sure that this webinar will continue to be updated as we get more and more information. So I wish you all the best and congratulate you for this effort. Thank you very much.
Thank you, sir. This whole series of 16 webinars developed in over last 3 months by effort of almost 45 faculty members all over the country, various AIIMS, AIIMS, PGI, AFMC, and hospital in Mumbai. So we need to thank all the people because it is a combined effort, and I request Professor Rakesh Lodha just a token of thanks for all of them.
Thank you, sir. It's my pleasant duty to thank all who have supported this initiative. Let me first start with, Professor Guleria, Dr. Neena Raina, Dr. Rajesh Mehta, Dr. Durari, who have taken time out of their busy schedules to encourage us today and also give an overview about this pandemic situation as well as how do we go further. I would like to thank WHO SEARO for funding and supporting this initiative. And I think especially I would like to thank Dr. Rajesh Mehta, who has been in constant touch, guiding us and discussing various aspects and trying to look at overall content. So we are really thankful to him and the team at the WHO SEARO. The subject experts, as has been mentioned, from various medical institutions have contributed both as subject experts as well as the content has been reviewed by the subject experts. And the faculty members come from AIIMS New Delhi, PGIMR Chandigarh, AIIMS Jodhpur, AIIMS Raipur, AIIMS Bhubaneswar, Kokilaben Dhirubhai Ambani Institute at Mumbai, and Armed Forces Medical College. At the same time, I would also like to thank Dr. Durari, Dr. Anu, and the team at the WHO Collaborating Center for Training and Research in Newborn Health for their active support for developing these webinars. They provided the necessary guidance about the various technical aspects. The SET facility at AIIMS has provided us the infrastructure both for recording as well as for hosting these webinars, and I would thank their entire team. Mr. Kurian and his team were the ones involved in recording and developing these packages. So the work is still on, and we thank them for making the content available. And at the same time, I think I would also like to thank our team members, the research team members who are actively supporting this, the conduct of these sessions. And I think we need to thank all the participants, not just from the country and the Southeast Asia region, as well as the other countries who have taken time out of their busy schedules to participate in this initiative. So we wish, we are hopeful that the sessions are going to be useful, and we are having this available on YouTube. Subsequently, these would be available for viewing on our servers, and we'll be sharing the links for these as well. With this, I would like to thank once again everybody who has contributed to this initiative, and hand it over back to Dr. Kabra. Thank you.
Okay, thank you, Dr. Rakesh. Now we'll start our webinars. And as I told you in the beginning, there are 16 webinars, and that would be webcast over next 4 Thursdays at 12:30. And we'll be circulating the links for each day separately. And each webinar is between 10 to 15, 20 minutes. And at end of each webinar, there are 2 to 4 MCQs for self-assessment. So now we'll be starting with the first webinar that is on the overview of COVID-19 in children. And I request all of you to write comments as well as questions, because these first 4 sessions will be manned live, and we'll try to answer them, and we'll try to improve on subsequent screening of these. So please write your comments and questions in the chat box, and we'll start with the first webinar that is on the overview of COVID-19 infection in children.
As coronavirus, I am Dr. Nitin Dhochak. I will be discussing about overview of COVID-19 in children. We will discuss briefly about the SARS coronavirus 2, epidemiology of COVID-19, and how the pediatric disease differs from rest of the age groups. Early in December 2019, there was an outbreak of acute respiratory illness in Wuhan city, China, and the number of cases kept increasing by late December. It was thought to have spread from Huanan seafood market, where various wild animals were being sold. The disease had marked similarities to the SARS outbreak of 2002 and 2003, and subsequently the etiological agent was identified as a novel coronavirus. WHO labeled the disease as coronavirus disease 2019 or COVID-19, and International Committee on Taxonomy on Viruses named the virus as SARS coronavirus 2. The virus was first isolated on 30th December 2019 from bronchoalveolar lavage samples. Coronaviruses have been causing infections in human beings previously also. These are spherical, medium-sized, enveloped viruses with positive sense single-stranded RNA. They cause respiratory, gastrointestinal, and central nervous system infections. Coronaviruses are genotypically classified in 4 subfamilies: alpha, beta, gamma, and delta. Alpha and beta groups cause human infections. Viruses causing previous pandemics, including Middle East respiratory syndrome and severe acute respiratory syndrome, and the current COVID-19 pandemic, belong to the beta group. Genome-wide analysis have shown that SARS coronavirus 2 shares nearly 80% and 50% sequence identity to SARS coronavirus 1 and MERS coronavirus respectively. This is the structure of SARS coronavirus 2. It has nucleocapsid composed of genomic RNA and phosphorylated nucleocapsid protein. On the surface, it has spike glycoprotein trimer S, heme agglutinin esterase HE, membrane protein M, and envelope protein E. ACE2 receptor on human cells is the target site where S protein binds and subsequently enters human cells. Coronaviruses have previously caused pandemic, although the number of cases were not as high as COVID-19 pandemic. It caused severe acute respiratory syndrome in 2002-2003. The virus was first detected in China in November 2002 and affected 26 countries later. It infected more than 8,000 people with a mortality of 10%. No new SARS infections reported since 2004. Later in 2012, another coronavirus caused Middle East respiratory syndrome pandemic. It first started in Saudi Arabia. Nearly 2,500 cases were reported with a mortality of 35%. The current pandemic is ongoing since December 2019. Briefly recapitulating the timeline of COVID-19, it began in Wuhan city, Hubei province, and probably from the Huanan seafood market. This is the publication on early cases and transmission dynamics of COVID-19. This picture highlights the series of events in December and January related to COVID-19. As we can see, cases of acute respiratory illness started in early December 2019. As highlighted, few cases were associated with seafood market exposure and few were not. Early in January, WHO was notified regarding the outbreak of illness. On January 8, China CDC announced that a novel coronavirus as the causative agent for this illness. By mid-January, cases were also reported in Thailand. Subsequently, the number of cases increased in China and in other countries. By mid-March, outbreaks have occurred in Europe, USA, and Japan. WHO declared COVID-19 as pandemic on March 11, 2020. In India, first confirmed case was reported in Kerala in January 2020. As of 20th August 2020, there are about 22 million cases with nearly 8 lakh deaths worldwide. In India, nearly 3 million cases are reported with 54,000 deaths. And these numbers are increasing day by day. Then discussing on COVID-19 infection in children, since early January, there have been cases of COVID-19 in children in China. In this article, they have described 6 confirmed children, of whom 1 required intensive care. This retrospective data showed that of 2,143 children, majority were having mild illness in 51%, 38% had moderate illness, and around 6% were severe and critical. And it was suggested that children are less affected and most are either asymptomatic or mildly symptomatic. Data from AIIMS Delhi also shows almost similar findings. Children less than 10 years constitute only 3.8% of the total COVID-19 cases and nearly 12% of all cases in age group less than 20 years. So why are children less affected? Multiple explanations have been given for the same. One reason is less exposure in children. Due to lockdowns, children do not have much of outdoor activity and there is less contact with peers at the usual hotspots for respiratory viruses, including schools and daycare centers. They probably have strong innate immunity due to repeated viral infections and probably vaccinations. They have a healthy respiratory tract due to less exposure to cigarette smoke and pollution. They have less frequency of underlying comorbid conditions, including diabetes, hypertension, and others. The receptor for SARS coronavirus 2, the ACE2 receptor expression, varies with age. It may have protective effect in lungs by limiting inflammation and capillary leak. And the regenerative capacity of alveolar epithelium is high in children compared to older adults. The clinical features also slightly vary from adults, like less frequency of fever in children reported in various studies. Nevertheless, most common symptoms in children include fever and cough. Majority are asymptomatic or mildly symptomatic. The severity classification of these children is based on WHO guidelines, which includes mild, moderate, severe pneumonia, and critical cases. Treatment depends on severity of illness. In mild cases, home management is done. It includes symptomatic treatment, including paracetamol, antihistaminics, ensuring adequate oral intake and isolation as feasible, and watch for danger signs. In moderate to severe cases, hospitalization is needed. The treatment includes respiratory support, hydroxychloroquine in moderate to severe cases, remdesivir, convalescent plasma, and tocilizumab may be used in selected severe cases. Then in end of April, there was an urgent alert by Pediatric Intensive Care Society from United Kingdoms. They had seen increased number of cases requiring intensive care admissions with hyperinflammatory state resembling toxic shock syndrome and Kawasaki disease. Then few cases resembling Kawasaki-like illness have also come up. Then a large case series of multisystem inflammatory syndrome was reported from United States, which included 186 children. Few case reports and series have been published from India also. Later, this hyperinflammatory syndrome was designated as multisystem inflammatory syndrome in children temporally related to COVID-19, also known as MISC. Various pathophysiological mechanisms have been postulated for MISC. Delayed hyperinflammatory response to SARS coronavirus 2 infection and a post-infectious inflammatory state are the most probable mechanisms. Other proposed mechanisms are inhibition of type 1 and type 3 interferon response by the virus initially and then delayed cytokine storm, or probably the virus acts as an intermediate trigger or portal for entry of unknown trigger. So with all these mechanisms, it leads to cytokine storm and end organ dysfunction. Frequently, children with MIS-C present with GI symptoms and cardiovascular system dysfunction. Kawasaki disease and toxic shock syndrome are important differential diagnoses. Diagnosis of MIS-C is based on criteria laid down by WHO or CDC, which includes clinical features, elevated markers of inflammation, evidence of COVID-19 infection or contact, and other common causes should be ruled out. Steroids and IVIG are first-line drugs. Other treatment options include interleukin-6 and interleukin-1 inhibitors. Prognosis is good with appropriate treatment. To summarize, COVID-19 is a global health problem which affects children also. Most children have mild infection, but they should be appropriately monitored for severe disease. One should be aware of MIS-C and timely therapy should be administered if MIS-C is detected. If MIS is detected. Thank you. If MIS is detected. Thank you.
Now there are self-assessment MCQs too. So we'll show you for 45 seconds question 1 and then question 2.
If MIS is detected. Thank you.
So you can check your answers, and after this we'll move on to the second webinar of the series of today. And after 2 webinars, we'll have answers of all the questions or comments received in chat box.
I am Dr. Jagdish Goyal from.
The second webinar is on transmission of COVID-2 infection and its various route and possibility of other routes of transmission. So this is prepared by Dr. Jagdish Goyal and reviewed by Dr. Rashmi Ranjan from AIIMS Bhubaneswar and Dr. Meenu Singh from PGI Chandigarh. So now this is the second webinar by Dr. Jagdish Goyal.
I am Dr. Jagdish Goyal from All India Institute of Medical Sciences, Jodhpur. I am Dr. Jagdish Goyal from All India Institute of Medical Sciences, Jodhpur. In next 8 to 10 minutes, I will be speaking on transmission of SARS novel coronavirus 2 infection. The outline of my presentation will be what are different mode of transmission of virus, incubation period, what is the period asymptomatic and pre-symptomatic transmission, and at the end, I will discuss about preventive strategies based on mode of transmission. Primary mode of transmission, as we all know, is from infected person. Direct transmission occurs when person is in close contact. Current policy of at least 1 meter physical distance, which may lead to larger reduction of infection. However, 2 meters distance might be more effective as adopted by few countries. Transmission can also occur through direct inhalation of infected particles during coughing and sneezing in form of droplet infection, when particle size is more than 5 micrometer, and in form of aerosol when particle size is less than 5 micrometer. Droplet rapidly falls into ground by force or gravity, while aerosol evaporates and remains in air for hours. No definitive evidence of airborne transmission till date. However, there are concerns regarding airborne transmission in few recent papers. Transmission can also occur through fomites when fomites are soiled by infected respiratory secretions. Virus may be viable on surface for few hours to few days. Experimental data use high viral load to study viability of virus on different surfaces. Virus may remain viable on plastic for 72 hours, on stainless steel for 48 hours, on cardboard for 24 hours, and on copper for 4 hours. However, there is no robust data regarding association of virus transmission and temperature and humidity. In this picture, you can see how the virus spread through close contact, airborne transmission, and how it spreads through fomites. Airborne transmission may occur. Airborne transmission may occur with particle size less than 5 micrometer, as they remain in air for long period up to 3 hours. Transmission can occur more than 1 meter distance. Airborne transmission can also occur during an aerosol generating procedure. Information on risk of transmission is from speculative data during SARS outbreak. This was the study published in year 2012, and you can see the risk in different aerosol generating procedure. Virus is also detected in non-respiratory specimen. It may remain viable in stool for more than 30 days and in blood up to 14 days. There are few papers regarding presence of virus in ocular secretion and semen also. Role of transmission of non-respiratory specimen remain uncertain. Fecal oral route is not significant for transmission. Virus is also detected in blood. Risk of blood-borne transmission likely to be extremely low through blood product and through needle stick injury. There is no evidence of transmission through contact with mucous membrane site. In this figure, you can see the median incubation period of virus, which is around 5 days. Most of the patients become symptomatic within 11 days. This figure shows the period of infectivity. Viral shedding occurs 2 to 3 days before appearance of symptoms. Infectivity declines significantly 8 days after symptom onset. There is a lot of debate regarding asymptomatic transmission. People who are infected but never develop symptoms are defined as asymptomatic transmission. Transmission from asymptomatic individual is difficult to study. Information are gathered from detailed contact tracing from few countries. Asymptomatic are less likely to transmit virus than those who develop symptoms. Risk of transmission in asymptomatic person is very low. Pre-symptomatic transmission is defined as people who infect other before they develop symptoms. Pre-symptomatic transmission has been studied in Singapore and it was found to be happen in 6.4% of cases. It occurs 2 to 3 days before appearance of symptoms, and now modeling studies suggest up to 44% of transmission occur before onset of symptoms. Transmission effectively occur in close contact and family members. Secondary attack rate among household contact was found to be 12.4%. Older individuals are more susceptible. Transmission usually occurs during incubation period. Infectivity is more during incubation period than during symptomatic period. Based on mode of transmission, there are various preventive strategies: case identification and isolation, quarantine of all close contacts, droplet precautions, airborne precautions, particularly during aerosol generating procedure, use of medical mask, practice of frequent hand hygiene. One should avoid crowded place and close contact setting, use of fabric mask in crowded place. To summarize, primary source of SARS novel coronavirus to infection is from infected person. Transmission of virus can also occur by close contact and droplet. Virus is also detected in non-respiratory specimen and secretions, but role in transmission remain uncertain. Median incubation period of virus is 5 days. Asymptomatic and pre-symptomatic transmission can occur in close contact and family members. Emphasizing preventive strategies is important to halt the progress of virus. Thank you for your kind attention.
Now you can see some MCQs for self-assessment. This is question number 1. You can just see, mark your answer, and you may be able to confirm at the end of this webinar.
Thank you for your kind attention. Thank you for your kind attention. Thank you for your kind attention.
Thank you.
I request all the participants to mute your mic so that there is less of a disturbance and other people can hear it appropriately. Now we'll move on to the third webinar of today, and that is on the clinical features of COVID in children, and it is prepared by Dr. Arvind Kumar from the Armed Force Institute of Medical Sciences, Pune, and Dr. Kanaram Jat from Department of Pediatrics. And it was reviewed by Dr. Praveen from AIIMS, Jodhpur. So, clinical features of COVID-19 infection.
Arvind from FMC, Pune. This webinar is about clinical features of COVID-19 in children. In this webinar, we will discuss briefly about demography of COVID-19 in children. After that, we will discuss clinical features among various categories like classical and atypical features. In this webinar, we will discuss briefly about demography of COVID-19 in children. After that, we will discuss clinical features among various categories like classical and atypical features. And then we'll discuss various severity of disease in children and risk factors for severe disease. So children of all age group from neonatal to adolescence age group can get COVID-19 infections. Pediatric age group comprise about 1 to 10% of total cases in various countries. And if we see in India, about 4% of total cases are below 10 years of age. And 7% of total cases are between 11 to 20 years of age. Among children, according to one study, 15% are less than 1 year of age. Children usually get infections from household contact. There is no gender predispositions, and according to one small study from USA, it shows predilections for ethnic minority. If we see incubation periods, it's about 4 to 5 days, but ranges from 2 to 14 days. Now let's see clinical feature of COVID-19 in children. Clinical features of COVID-19 may be categorized as pre-symptomatic, asymptomatic, classical manifestation, and atypical symptoms. Pre-symptomatic is time period between exposure to virus and development of symptoms. And it's same as incubation period. Pediatric data, though, are limited, but children may be infectious during this period. Asymptomatic infection is defined as positive nucleic acid test for corona, but without any sign symptoms, and the chest imaging is normal. This test usually done for family screening, contact tracings, or as a part of study. Prevalence of asymptomatic infections varies from 4 to 27% in different countries, but it may not be a reflections as asymptomatic children are usually not tested. The asymptomatic child may transmit infections. Children with COVID-19 typically presents with fever, cough, respiratory difficulty that's similar to other viral infections. This table shows clinical feature from 11 studies, all from China, included 333 children. Here, asymptomatic infections range from 0 to 35%, fever, cough markedly varied from 11% to 19%, range up to 100%. And this may be due to many small studies included in this review. Other features included pharyngitis, rhinorrhea, wheezing, diarrhea, vomiting, headache, and fatigue. This table shows clinical features from various countries. Fever was most common, present in only 50 to 60% cases. Cough was present in about 50% cases. Rhinorrhea ranged from 7 to 20%, and about 10 to 20% had nausea, vomiting. 8 to 13% had diarrhea. Sore throat was reported from for 24% children, according to one study from USA. Here are two systematic reviews showing clinical feature in children. One on left side included 1,667 children. and on right included 2,500 children. In both review, fever was most common in about 50 to 60% children, followed by cough about 40 to 50% children. Both fever and cough were present in only 30% cases. Nasal symptoms were less common. Nasal symptoms were present only in 10 to 20% cases. Myalgia were present in 8 to 18% cases, sore throat in 6 to 18%, vomiting and diarrhea in about 6 to 7% cases. Headache was present in about 4% cases. In this table, it shows clinical features of various age group in children. Infant had more cough, more rhinorrhea, more diarrhea compared to older children. Infants may have difficulty in feeding also. Children of 10 to 19 years of age had more myalgia, headache, loss of smells, or less loss of taste. But it may be because that younger children will have difficulty in expressing these symptoms. Here is some difference in clinical feature from adults. Both cough, fever, and fever was more in adults compared to children. Similarly, adult had more shortness of breath, myalgia, headache, and diarrhea. Nasal symptoms are less in both children and adults. Few children may have atypical presentations also. These include isolated GI symptoms in form of diarrhea, vomiting, and pain abdomen. COVID-19 can also have skin manifestation in form of rash, reddish purple nodules on digits known as COVID-19 toes. One unique presentation in children is MISC, multisystemic inflammatory syndrome in children. About that, we will discuss in separate webinar. After clinical feature, now we'll discuss about severity of COVID-19 in children. And we can classify the severity as asymptomatic, mild, moderate, severe, and critical. Asymptomatic infections had no clinical signs and symptoms, normal chest imaging, but positive RT-PCR or antibody test. Mild infection is defined by presence of fever, cough, myalgia, sore throat, running nose, GI symptoms, etc. But there is no tachypnea or no chest abnormality in imaging. Moderate infection had pneumonia defined by presence of fever, cough, and tachypnea, or chest injury, or presence of wheezing or stridor on auscultations, or abnormality of chest imaging, but it is without hypoxemia or shortness of breath. Severe infection is defined by presence of dyspnea, hypoxemia, or cyanosis, or severe diarrhea, or presence of general danger sign like inability to breastfeed, or inability to drink, presence of lethargy, presence of unconsciousness, or presence of convulsions. Critically sick children had presence of ARDS, respiratory failure, shock, encephalopathy, heart failure, acute kidney injury, or multiple organ dysfunctions. Here is severity of disease in children in various studies. Table on left shows a study from China where about 13% cases were asymptomatic, 43% had mild, 41% had moderate, 2.5% had severe infections, and only 0.4% had critical infections. Table in middle is from systematic review that shows asymptomatic infections in 19% children, mild in 94%, and severe in 3% children. But they did not report about moderate symptoms. Another systematic review that included 1,121 children showed asymptomatic infection in 14%, mild in 56%, moderate in 46%, severe infections in 2.1%, critical infections in 1.2%. So in summary, majority of children had mild to moderate infections, and only 2.4% had severe to critical infections. In another systematic review included 7,780 children. Only 7 children died, and less than 1% required mechanical ventilations. Death among severe and critical ill children was high, and it ranged from 4 to 18%. If we see risk factor for severe disease, one is younger age group, particularly infancy. In this table, proportion of severe infection and critical infection cases were high in infants and asymptomatic cases were less. That is around 1.9%. Even rate of hospitalization was high for infants compared to older children from USA, 15 to 62% versus 4 to 14% in older children. The next risk factor for severe disease was underlying disease. In a study from France, around 70%, and a study from USA and Canada, around 83% of severe and or critically ill children had underlying disease that included neurological, respiratory, immunosuppressants, obesity, diabetes, etc. Other risk factors included older children age group 15 to 18 years, minority population of USA, male gender, presence of hypoxia, presence of thrombocytopenia, and raised serum CRP level. So in summary, all age group of children can get COVID-19 infections. Most of children can get infections from household contacts. And most common symptoms are fever, cough, respiratory difficulty. Children may have atypical participation too. Majority of children get mild to moderate infections, and infancy and pre-existing medical conditions are risk factor for severe infections. Thank you. Thanks for patience listening.
Unmute के ठीक है
আসো টেবিলে আসো
Please. Now, the next webinar is on diagnosis of COVID infection in children, and we'll be answering all the questions after this webinar. Please write your questions in the chat box of pediatrics team. So, this diagnosis of COVID-19 has been prepared by Dr. Saran and reviewed by Dr. Joseph Matthew, Dr. Tanu Singhal, and Dr. Nitin Dochak. And you will see now how to make a diagnosis.
Ever since being declared a pandemic, hello everyone. I'm Dr. Sharan from the Department of Pediatrics. Ever since being declared a pandemic in March 2020, COVID-19 has spread across the globe, affecting more than 213 countries and claiming over 7 lakh lives. Knowledge of its diagnostic tests are still evolving, and it is important that we have a clear understanding of the various tests available and their interpretation. Here is a brief outline of our presentation. We'll be touching upon the WHO case definitions, the latest testing guidelines by the ICMR, and the different samples used, and also we shall be briefly looking into each of the various testing methods available. The novel SARS coronavirus 2 is a RNA virus, and it is around 200 nanometer in size. It binds to the ACE2 receptors through the spike glycoprotein, which is central to its pathogenesis. Neutralizing antibodies seen as early as the first week after symptom onset, they are directed primarily against the S, that is the spike protein, and the N nucleoprotein. Incubation period, that is the time between exposure and the onset of symptoms for COVID-19, ranges from 2 to 14 days and an average of 6 days. WHO has listed case definitions for the purpose of risk stratification of individual patients and to help us in the optimal utilization of the limited testing resources that we have. A suspect case is defined as any person an average of 6 days. WHO has listed case definitions for the purpose of risk stratification of individual patients and to help us in the optimal utilization of the limited testing resources that we have. A suspect case is defined as any person with fever and respiratory symptoms like cough, breathlessness, sore throat, etc., and a history of travel or residence in an area where there is ongoing transmission of COVID-19 14 days prior to the onset of symptoms. For example, any person residing in or with a history of travel to a hotspot or a containment zone develops symptoms within 14 days of return, then he or she is a suspect case. Similarly, if a patient develops symptoms within 14 days of having contact with a probable or a confirmed case, then he too should be called a suspect case. Also, if there is no other alternate explanation for the patient's respiratory illness, then he too will be grouped under an average of 6 days. WHO has listed case definitions for the purpose of risk stratification of individual patients and to help us in the optimal utilization of the limited testing resources that we have. A suspect case is defined as any person with fever and respiratory symptoms like cough, breathlessness, sore throat, etc., and a history of travel or residence in an area where there is ongoing transmission of COVID-19 14 days prior to the onset of symptoms. For example, any person residing in or with a history of travel to a hotspot or a containment zone develops symptoms within 14 days of return, then he or she is a suspect case. Similarly, if a patient develops symptoms within 14 days of having contact with a probable or a confirmed case, then he too should be called an average of 6 days. WHO has listed case definitions for the purpose of risk stratification of individual patients and to help us in the optimal utilization of the limited testing resources that we have. A suspect case is defined as any person with fever and respiratory symptoms like cough, breathlessness, sore throat, etc., and a history of travel or residence in an area where there is ongoing transmission of COVID-19 14 days prior to the onset of symptoms. For example, any person residing in or with a history of travel to a hotspot or a containment zone develops symptoms within 14 days of return, then he or she is a suspect case. Similarly, if a patient develops symptoms within 14 days of having contact with a probable or a confirmed case, then he too should be called a suspect case. Also, if there is no other alternate explanation for the patient's respiratory illness, then he too will be grouped under a suspect case. In a setting of a pandemic, individuals fitting into these criteria are highly likely to be infected with the virus and have to be prioritized for early testing and isolated in a timely manner to prevent further spread. A probable case is one where a suspect case could not undergo testing for some reason or the testing was inconclusive. Confirmed case is one with confirmation of infection through nucleic acid detection. For its testing guidelines, ICMR prioritizes testing of patients with influenza-like illness, abbreviated as ILI. It is defined as presence of fever, that is temperature of more than 38 degrees centigrade, and respiratory symptoms like cough, breathlessness, and sore throat. ICMR recommends testing individuals who develop this influenza-like illness within 14 days of return from overseas, or in migrants developing ILI within 7 days of return from their hometowns. Also, hospitalized patients, frontline workers, and healthcare workers developing influenza-like illness have to be tested. Asymptomatic individuals who have contact with a confirmed case should be tested between 5 to 10 days after their last point of contact. This is keeping in mind the maximum viral load being present during the initial phases of illness and the average incubation period, which is 5 to 7 days. Hence, testing the individual between 5 to 10 days of exposure is likely to have a better yield. Severe acute respiratory illness, that is SARI, is defined as patients with the fever and respiratory symptoms that warrant hospitalization. These patients need to be tested regardless of their history of exposure. Upper respiratory samples like the nasopharyngeal and throat swabs are most widely used for the diagnosis of COVID-19. Sample collection is an aerosol generating procedure and poses a potential risk to the healthcare workers and warrants donning with appropriate PPE. Saliva is emerging as a substitute specimen for virus detection. Data is still emerging, but it is said to be 90 to 95% sensitive in comparison with nasopharyngeal swabs. Rationale behind using saliva as a suitable specimen is: one, salivary glands are rich in ACE2 receptors and could potentially harbor the virus during the acute symptomatic phase. Secondly, sample collection is safe and cost effective, and it does not require trained personnel donned in adequate PPE. Bronchoalveolar lavage is primarily used in intubated patients and is said to have a better yield than upper respiratory tract specimens. The serum is used for testing antibodies. It is useful to detect past infections and knowing the seroprevalence for epidemiological purposes. RT-PCR is the gold standard test for COVID-19. Let's briefly look into its steps. The virus is first deactivated from the sample by using lysis buffers, after which they are treated with a reverse transcriptase enzyme. So this reverse transcriptase enzyme generates a complementary DNA from the viral RNA. Next, we use primers and DNA polymerase, like the Taq polymerase, to identify specific viral nucleotides like the N gene, S gene, etc., and amplify them in logarithmic proportions. So the primer, which is synthesized in vitro, attaches to specific viral nucleotide sequences and activates them. The DNA polymerase further amplifies them. An activated Taq polymerase also triggers the Taqman probe to emit light, and the amount of light is directly proportional to the amount of viral particles in the specimen. This light can be measured by the RT-PCR machine. Since it is a novel virus and has a very high rate of mutation, more than one primers are used for a single RT-PCR test. Pooled RT-PCR tests a maximum of 25 specimens in a single session of RT-PCR. In this, samples from 25 different individuals are tested as a single sample through the RT-PCR. A negative result labels all the samples as negative, and in case of a positive result, the individual samples are tested separately. Pooled RT-PCR can be applied in scenarios where there is a very low pre-test probability, that is, while screening asymptomatic foreign returnees or migrants from green zones. This makes for better economical use of our limited testing resources. CBNet works on principles similar to that of RT-PCR, and it is already well established in the diagnosis of tuberculosis. It involves an automated process where the sample is processed after being fed into the machine, and specific viral nucleotides are extracted by the machine, and it is further amplified similar to the RT-PCR technique. It is further detected by qualitative assays. Rapid Expert Express SARS coronavirus 2 has been validated by multicentric trials and is found to have comparable sensitivity and specificity as the RT-PCR. It detects the N and the E gene and has a turnover time of about 45 minutes. The CBNet, although more feasible than the RT-PCR, still requires a 24-hour air conditioning and an uninterrupted electrical power supply for its smooth functioning, which is not feasible in most of the peripheral health settings in India. It is used when results are required fast and patients are not symptomatic or mildly symptomatic and are going for urgent procedures like surgery or endoscopy. TrueNet is a mini version of the CBNet or the Gene Expert, and it has a turnover time of approximately 1 to 1.5 hours. Being battery operated and portable, it can test up to 4 samples per batch. These features make it ideal for testing in peripheral healthcare centers, and it is found to have similar sensitivity and specificity to CBNet. A negative TrueNet result does not require confirmation by a RT-PCR. Rapid antigen testing kits have bridged the gap for need of a point-of-care test that is reasonably sensitive and highly specific. It gives the result within 15 to 30 minutes of sample collection, and it has been validated by both the ICMR and AIIMS and is found to have a sensitivity of 60 to 80% and a very high specificity of more than 99%. Current recommendation so all suspect cases with a rapid antigen test, and if positive, their results are interpreted as true positives. Negative results have to be reconfirmed by a repeat RT-PCR. After sample collection, the swab is drenched into a buffer solution where the viral particles, if present, are extracted. The solution is then dripped into a specimen well, and the card is read within 15 to 30 minutes of sample dropping. The assay detects the S protein of the virus, and which, if present, the specimen will give out a visible readout as shown here. Next, we come to the serological tests which are ELISA-based tests detecting both IgM and IgG antibodies against the nucleocapsid or the spike protein of the coronavirus. These tests indirectly measure the host immune response and are particularly useful in children with mild or moderate illness who usually present late. IgG and IgM titers are found to appear at similar time points, that is after the first week of infection, and peak at around third week of infection. IgM titers have shown to decline subsequently, whereas IgG are said to last longer. Recent tests have shown that these antibody tests have a very high specificity of more than 99% and a sensitivity of 90% at the end of first week and 96% at the end of 2 weeks. Utility of serological tests is primarily to estimate the burden of the disease in the community and detecting past infection, especially in children who are usually asymptomatic and present late. A positive antibody test does not mean the person is immune to COVID-19. Currently, there is no evidence to suggest that seroconversion prevents further infection. Other non-specific lab parameters include lymphopenia, race, CRP, D-dimer, and ferritin, fibrinogen, and IL-6 levels. Additionally, multisystem inflammatory syndrome is characterized by elevated inflammatory markers along with raised creatine phosphokinase, troponin I, and dilated coronary arteries and reduced ejection fraction as seen in echo. Repeat testing prior to discharge is recommended only in severe cases, that is, patients with a respiratory rate of more than 30 or saturation of less than 90% on room air, or patients who developed ARDS or shock. Immunocompromised patients have shown to shed viruses for a prolonged period of time, and testing them negative prior to discharge is also being practiced. Studies have shown that the most common CT finding in children is the presence of ground glass opacities, subpleural in location, mainly involving the periphery and the posterior lungs. Image A shows a distinct ground glass opacity involving the posterior aspect of the right lung, which is well localized. Image B shows consolidation in the inferior lobe of the left lung surrounded by ground glass opacities. Image C is that of a child with severe disease showing diffuse consolidations and ground glass opacities in both lungs. To sum up our presentation, RT-PCR in an appropriately collected nasopharyngeal swab is the gold standard for diagnosis. CBNAT and TrueNAT have been validated and do not need a confirmatory RT-PCR. Although not very sensitive, rapid antigen test is emerging as an ideal point of care for screening. A negative RT-PCR does not rule out COVID-19 infection, and as a single RT-PCR test has a sensitivity of around 80%, antibody tests have no role in diagnosis of active infection. Thank you.
So we have finished 4 webinars which were scheduled for today's presentation. Now all these webinars are available on AIIMS Telemedicine YouTube. AIIMS Telemedicine YouTube. YouTube channel. You can see them again. And now I hand over to Dr. Rakesh Lodha for answering all the questions and comments which we have received in chat box. Dr. Rakesh.
Yeah, so we have received a few questions on both this platform and the YouTube platform, and we'll try and answer these questions. And you could still continue to type your questions on both the platforms. So I think I'll first ask Nitin. This is a general question, and some of these would be taken up in webinars later on. What are the prophylactic medicines for prevention of COVID-19? Dr. Nitin.
So, as such, as of now, no medicine is proven as a prophylactic medicine for COVID-19, and all this hydroxychloroquine or multivitamins, these are not proven therapies. So, better will be to have a good nutrition and good hydration, and as soon as symptoms are present, you need to get tested, and according to the severity of illness, then it should be managed. Per se, awaiting a good vaccine, till now there is not a good any prophylactic medicine.
Okay, so I think we'll move on to another one, which is about that whether a COVID-19 patient is more infectious in pre-symptomatic period. So again, I think Nitin, because you covered that part, you could answer this.
So it's not so that the patient is more infective in pre-symptomatic period. So the infectivity period, it lasts around 2 to 3 days prior to the symptom onset, and maximum infectivity is within first week of after starting of symptoms. And patient is symptomatic and can transmit infection in this duration. But what happens is that in pre-symptomatic period, the person is not aware, and he will not be following the isolation precautions at that time. So it is possible that he will end up infecting multiple people at that time. And once the person is symptomatic and the isolation precautions are started, so the patient might be transmitting to less people. But because if we see the viral loads, they start before the symptom onset and they present throughout the first week of illness. So the patient can transmit, but maybe due to better isolation precautions after becoming symptomatic, the transmission risk decreases a little.
I think so. I think within that, you partly answered another question, which is about how long does the host remain infectious after infection with the coronavirus? And there are certain questions related to the period of quarantine. So maybe we'll take this and then, yeah.
So again, the maximum infectivity after symptom onset is within the first 7 days. And you might find virus in this specimen, the nasopharyngeal specimen, even after that. It is little difficult to comment whether these are dead viruses, the RNA being detected from a dead virus, or they are still infective. So it is a good practice to go for isolation for 7 to 10 days, even after the patient becomes asymptomatic. But the maximum infectivity is within the first 7 days of symptom onset.
So that, again, I think partly this issue about because we are using RT-PCR for diagnosis, and RT-PCR may continue to be positive even when there's no viable virus. Currently, the guidelines do not recommend repetition of testing, particularly in people who have asymptomatic infection or have mild symptoms. And therefore, there was a question about whether the asymptomatic patient who was COVID positive, can they go out after 14 days even if they are RT-PCR positive? So these tests do create a bit of confusion because it's difficult to say just on the basis of test positivity whether the person is infectious or not, particularly in this setting. So I think one would just follow the period of, the recommended period of isolation in these settings, just to make sure that the chances of transmitting the infection are reduced. But as of now, the agencies do not recommend repeat testing for people who had asymptomatic or mild symptomatology. I'll ask Dr. Kabra about a question. There's a question about how we can differentiate normal flu from COVID-19. This is something that's going to be common.
Yeah, it's very difficult to differentiate as the clinical symptoms are similar to any of the common respiratory viral infection. It's very difficult. If we see the epidemiology, then there is more chances of fever, less of cold, and more of a sore throat in COVID infection. But all these data are biased because we are taking children only for testing if they are having a fever or sore throat. So it is very difficult and it is not possible to differentiate clinically.
Okay, so I think this is important, and we'll just move on to a few sets of questions around symptoms. So can COVID-19 Yeah. So can COVID-19 case present only with respiratory symptoms without fever? Yes, that could happen. There would be a set of people who would have only mild respiratory symptoms, no fever, no other systemic features, or they may have just respiratory symptoms with maybe myalgias. And these would come in the category of symptomatic patients only. These would not be classified as asymptomatic patients. Then there are a few questions around, again, I think taking up the diagnosis part, the specificity of RT-PCR. So the specificity of RT-PCR, the way the different test kits that are available, they kind of come in or are permitted only after the sensitivity specificity are proven to be high. The specificity would be close to 100%, means it would be nearly 19, more than 99% specificity would be there. The sensitivity variable reports may be there, and this has to be, also one has to consider issues around sampling. If the sampling is not good, then we are likely to miss cases of COVID infection, even if the test has been done properly. There's also a question around whether we need to consider the cycle threshold value which we get on RT-PCR, and is there a relationship to infectivity? So the cycle threshold kind of just gives us an idea about the viral load. So if the CT value is low, let's say, if it is 20 versus another sample where the CT value is 30, the viral load would be higher in the first sample than the later one. Now, only thing that we need to keep in mind is that unlike a body fluid like blood, where we know that there's a, let's say if we took 1 ml sera, we can say compare 1 ml to 1 ml sera of different people. But when we are taking respiratory specimen and we are putting into a known amount of the viral transport media, the issue is that we don't quantify how much sample we have obtained from different individuals. And therefore, while these values may be indicative, it would be difficult to really strictly follow these for either determining the, let's say, association with severity or infectivity. So one would just one cannot really rely too much on these values as far as deciding about the viral load overall, relationship with the severity or risk of transmission. There's a certain set of questions around the role of ivermectin and HCQS for prevention, is there particularly in children?
So as it has already been pointed out, there are no preventive medications approved or having evidence of efficacy. So no role of ivermectin, no role of hydroxychloroquine for prevention, as well as of now, there are no evidence to support even for the treatment in mild to moderate diseases. So I again re-emphasize no role of, as of now, there is no evidence to suggest preventive role of vitamin C, zinc, hydroxychloroquine, or ivermectin.
Okay, so we have one question asking about, whether when children we are worried about vaccinations. So should live vaccines be avoided in children suspected to have COVID-19? So maybe, Nathan, would you like to take this?
So again, it will be like any other viral URI or respiratory tract infection. So if it is a mildly symptomatic patient, we might go ahead with the live vaccines. But in severely affected patients, we should avoid live vaccines when the patient is suspected or confirmed case of a COVID. And there is some evidence that it might be the COVID, severe COVID is associated with lymphopenia. So it might affect the efficacy of vaccines also. So in severe cases, we should avoid vaccination. In mild infection, we might give vaccine.
So thanks, Nathan. So we have a few questions regarding survival of the virus on surfaces like silicone self-inflating bags, tubes and all, which are used in the ICU. survival of the virus in a dead body and dead body handling. So some of these aspects we're going to be covering in detail in subsequent webinars. But briefly, what we could say is that the information regarding the duration of, the presence of viable virus in a dead body, definitive data are not there. But at the same time, there are guidelines to handle the dead bodies carefully, and that those protocols are going to be discussed. At the same time, we also need to be clear that this most of it would be related to the secretions. It would not really be an aerosol generation that would be happening from dead bodies. We just need to take the precautions, and details are going to be covered in the subsequent webinars. The information on survival or detection of viable virus on different surfaces has been evolving over a period of time. And it may be, just a few hours on some paper surfaces. On plastics or synthetic surfaces, it may be a few days, about 3 to 5 days. Surfaces like, when we are using polypropylene or the face masks which are used, it may be about 7 days or so. So some of these are likely to be there. But at the same time, what I would like to emphasize is that whatever equipment or disposable, or let's say self-inflating bags and ventilator circuits that we are using in the ICU or in the hospital setting, we will need to follow the usual infection control practices. So a self-inflating bag after use on a patient would have to be cleaned and disinfected soon after the use. And that would reduce whatever risk is there of the virus being present on these surfaces. There is another question, and I think some of these will be taking up in detail, but what medicine to give to a patient with consolidation on imaging but is asymptomatic? So, Nathan, would you take this?
Again, it will like a patient who is having finding on imaging but is not symptomatic. So we will have to, so some of these patients might have some, like if you use a very sensitive imaging like a CT scan, you might find some ground glassing in some areas. But if we have to treat it according to the symptomatology and severity of illness of the patient. So like the current guideline will not recommend any medication for such a patient, and this patient will be classified as a asymptomatic patient.
Okay. So I think there are concerns about reinfections among patients who have recovered, not specifically for children, but I'll ask Dr. Kabra to shed some light on it, the risks of reinfection, how common it is.
It is being considered in some patients, but it is extremely low. And even from India, around 3 patients have been reported to be having reinfection. All over world, there are few cases which has been shown that yes, there may be reinfection, but the data emerging as of now, there is not much data to support that all these patients who have recovered may get a reinfection. But we can consider by general immunology that any viral infection in next 2 to 3 months, there is less likely that there will be a reinfection. Similar should be applicable to COVID, but as we are learning more and more about COVID, as of now, we may not be very sure about the chances of reinfection, but it is extremely low.
There's another question about the anosmia part, a clinical feature with absence of other symptoms. How reliable it is as a positive COVID symptom where community transmission is reported. So again, anosmia may happen with various viral infections. It's not really specific for COVID infection. And it may occur, so this alone may not really be an indicator. One would have to go for the testing with whenever it's been suspected. And at the same time, the return of spell cannot be considered as as recovery. So that recovery is going to be variable in different people. We are still following the usual guidelines of allowing after the asymptomatic period, the criteria for discharge or end of the period of isolation. So roughly that would be about close to 2 to 2.5 weeks of isolation after onset of symptoms, within which we would expect the patient to recover completely. And same period would also be applicable to the asymptomatic individuals. We have a question about how many days the babies have to be isolated at home after mild to moderate symptoms. So I think this we're going to discuss in detail in the next webinar. But primarily, as I said earlier, that the guidelines for these children would be similar to what's there overall, that the child has to be asymptomatic. So approximately after the onset of symptoms, about 2 to 2.5 weeks is what's the duration of isolation that's recommended. I think there's a question related to the one which was asked that if you see consolidation on CT and the child individual is asymptomatic, should steroids be started? So I think general thing is that in an asymptomatic person in particular, one is not recommending any advanced imaging like CT scans and all. There are going to be some findings which are going to be there, and that really doesn't warrant any specific treatment. For steroids, there are definitive indications that it's likely to be beneficial only in those who have moderate to severe disease, and one shouldn't really be using it otherwise. So these are, I think we have addressed almost all the questions that have been there in the chat box. And I think I'll hand it over back to Dr. Chandra.
Okay, so we come to end of today's session, and I again repeat, we'll have a next session on next Thursday, that is 22nd of October at 12:30, and we will be circulating the link for that. And all the webinars are available on AIIMS telemedicine website. You can read them. YouTube channel of AIIMS telemedicine. And next Thursday, same time, on 22nd of October, we'll have assessment of severity, treatment of mild symptomatic, moderate to severe illness, and care of newborns. All these four, that will answer all the questions which today even some people have asked. Thank you very much. Join us again on 22nd at 12:30. Thank you.
Di Malal.